Thank you. Thank you so much. It's great to be here with you. This must be over 25 years that I've been coming to this event, and it's always a wonderful time. What an honor to deliver this year's A.T. Still Memorial Lecture, and special thanks to Dr. Ira Manka, our wonderful AOA president and graduate of the UMDNJ School of Osteopathic Medicine, class of 1984, who was a student of mine early in my career. I guess I did a good job, right? A special thanks also to our AOA president-elect, Dr. Teresa Hubka, and to AOA's Chief Executive Officer, Kathleen Creason. Great presentation today, thank you. And to the AOA past presidents and the AOA Board of Trustees, many of whom are mentors and friends, thank you. A special thanks to our speakers today, Dr. Ray Morrison and Vice Speaker, Dr. David Broder, who always do a wonderful job at this event. I'm happy to be part of the New Jersey delegation, the great New Jersey delegation right here, led by our president, Dr. Dan DeFeo, and including many of my colleagues from Rowan Virtual School of Osteopathic Medicine. I would like to dedicate this lecture to my late wife, Donna, who was an amazing wife, mother, and nurse. And without her support and encouragement, I would not be here today. Thank you. This lecture is entitled Osteopathic Medicine Today. What would A.T. Still have to say? To theorize what Dr. Still would have to say in the present day, I've analyzed his life and work through the lens of my career as an academic geriatrician and a former dean. I would speak what I believe he would say, how we can contribute to change our healthcare system to better improve the quality of life of our nation. A.T. Still worked within and then rebelled against a broken healthcare system. He founded osteopathy in June 1874 due to his disdain for a healthcare system that subjected patients to extreme treatments that included bleeding them for nearly until they became unconscious, or prescribing poisonous dosages of mercury. Dr. Still's disillusionment with American medicine was furthered through witnessing the disastrous effects of opium, morphine, and cocaine that were commonly prescribed and had made addiction a serious public health problem in America, not unlike today. Dr. Still wrote that, "By day and night, I saw legions of men and women staggering to and fro all over the land, crying for freedom from the habits of drug and drink." When he sought to know what the cause was for what he referred to as so much death, bondage, and distress, Dr. Still concluded it was the ignorance of our schools of medicine. Adding to his belief that American medicine was woefully inadequate was his observation while working as a hospital steward during the Civil War that children who fell ill where medical care was not available did not die from their illnesses. The deaths of 3 of Dr. Still's children from spinal meningitis in 1864 convinced him of the brokenness of the healthcare system and its ineffectiveness. The doctors came and were faithful in their attendance. Dr. Still wrote of the physicians who treated his children. "Day and night they nursed and cared for my sick and administered the most trustworthy remedies, but all to no purpose. In his grief, Dr. Still committed himself to charting a better path for American medicine through finding what biographer Carol Trowbridge described as better methods of healing. Dr. Still would undoubtedly believe we've come a long way since then. However, as our ACOM president, Dr. Bob Kane, so eloquently stated at this year's Educating Leaders Conference, our healthcare system is still broken. I would like to explain from the perspective of a geriatrician how our healthcare system is inadequate and unprepared for our nation's growing number of older adults. With the aging population, more of the physician's time will be spent caring for the complex needs of the elderly. Many physicians, especially primary care physicians and many medical subspecialists, will be spending 50% or more of their time caring for people over 65. They will be managing medical and non-medical needs that will pose significant challenges to older people, to their caregivers, and to healthcare providers. The current U.S. healthcare system is not aligned with the complex needs of older adults. The elderly are managed with increasing number of medications, exposing them to adverse drug reactions. They experience transitions of care from the home to hospital to subacute units, nursing homes, etc., that often lack coordination of care and continuity. Their care is fragmented, placing them at risk for hospital readmission, visits to the emergency room, adverse drug reactions, delirium, and so forth. We've all seen this. Exacerbating these challenges is the fact that this care is delivered in the context of payment models that fail to account and adequately reimburse for the time and effort needed to provide the quality of care for patients with their many complex needs. And I commend our AOA, ACOI, and many of our specialty colleges who are addressing this issue from an advocacy standpoint. In addition to all this, geriatricians, the physicians with the requisite training to optimally care for the growing segment of the population, are in increasingly short supply. Dr. Still's response to a broken healthcare system of his time was to found osteopathic medicine, and with it the profession's first school, the American School of Osteopathy, now A.T. Still University. It was there he sought to educate osteopaths to his new approach to medicine. Similarly, in the 1980s, developing the field of geriatrics and training geriatricians was seen as the way to treat the complex care needs of older people. In our profession, both the ACOFP and the ACOI embarked on developing this discipline and created geriatric medicine fellowships rooted in the osteopathic approach. These programs were designed to train our physicians to optimally care for older adults across the care continuum, as our unique, integrated, body, mind, spirit approach to patient-centered care made us well-suited for developing this new discipline. Projections were made regarding the number of geriatricians that would be needed to care for the growing number of elderly, a goal that has been impossible to achieve. Since it's not possible for us to train sufficient numbers of them to directly care for the growth of the elderly population, we will instead need geriatricians to serve as educators to the physicians who will soon be spending more of their time caring for the elderly. Who better to respond to the needs of older adults than osteopathic primary care physicians? Our graduates are more likely to go into primary care serve in rural and underserved areas, and have the skill set needed to care for the elderly. Currently, there is a movement in America striving to provide better care for older adults. It's called the Age-Friendly Health System. It's an initiative supported by HRSA and other organizations that works to ensure that care delivered to older adults is really age-friendly. What constitutes age-friendly healthcare are 4 evidence-based practices referred to as the 4 M's. They stand for as follows. First is what matters, which seeks to align the care according to older persons' preferences. Of course, we refer to this as caring for the whole person, what matters. The second M is medication. That's avoidance of medications with deleterious side effects, and we do this best. The third M is mentation. We talk about caring for body, mind. This is mind. That is the management of depression, dementia, and delirium. And of course, the fourth, mobility. Maintaining mobility, structure, function, keeping our patients active physically. This is a very holistic osteopathic approach to care. Let me tell you about a patient of mine, this is not her real name, that I cared for several years ago as a young internist geriatrician that illustrated the 4 M's, especially what matters, a very holistic approach to patient care. Mrs. O'Neill was 96. She resided at the Manor at St. Mary's, a Catholic residential facility where I was providing care. She was a cellist. She was very articulate. She was very engaged, actively engaged in life. She presented to me after having a near syncopal episode and shortness of breath on Christmas Eve morning. She had a history of aortic stenosis, but she never had heart failure or syncope. On examination, she was tachycardic, she had rales, she had ankle edema. Her affect and cognition were normal. Because of the cardiac decompensation, I recommended hospitalization. Now, she usually would follow my recommendations, but this time she respectfully declined my approach. I gently said to her that I was concerned that without appropriate care, she may not make it. To which she replied, "Doctor, even if I went to the hospital, I may not make it." Tearfully, she said to me, her 2 grandsons, who she hadn't seen in over a year, would be joining her that day for the Christmas Eve celebration at St. Mary's, and she would be playing Ave Maria at the Christmas Eve midnight mass. She wanted to spend time with her grandsons, her only remaining family. I supported her decision, and after carefully reviewing her medicines, I increased her diuretics and nitrates and planned to see her in a few days. 2 days after Christmas, I returned to St. Mary's as part of my usual schedule. Mrs. O'Neill was first on the list to be seen that morning. Instead, I was called to her room. Mrs. O'Neill had passed away. As I mentally went through the checklist in order to pronounce her, I pondered whether I should have handled things differently. In death, Mrs. O'Neill had a very peaceful look on her face, and as I left, I noticed her cello sitting prominently on the chair next to her bedside. As I returned to the clinic, I learned from the staff how beautifully Mrs. O'Neill played Ave Maria during the midnight mass and how joyful she was to celebrate this holiday with her grandsons. As I prepared to see the next patient, I felt grateful for the humanistic and holistic approach to patient care embodied in our osteopathic tradition and what matters to our patients. This is why I think of Mrs. O'Neill each time I hear the song Ave Maria. As a geriatrician, I've spent a lot of time caring for patients at the end of life. There are still many unmet needs in this area. Only half of Medicare beneficiaries receive hospice services at the time of death. Osteopathic physicians are best suited for caring for persons at the end of life. Actually, Dr. Still's approach to end-of-life care reflects many of the principles of hospice care today. His approach was described in Arthur Hildreth's book, The Lengthening Shadow of Dr. Andrew Taylor Still. Hildreth was a graduate of the American School of Osteopathy's first class. In his book, Hildreth recounts how Still cared for Hildreth's father at the end of his life as a friend as well as a physician. According to Hildreth, Dr. Still was the only physician who rendered a service that in any way relieved the deplorable condition his father was in and contributed all there was in him, not only in trying to help father through his great trial, but also in a kindly, wonderful way, soothing the hearts of those of us who had to stand by and watch the passing of a loved one. The osteopathic approach to end-of-life care brings to the bedside not only a patient-centered holistic approach, but also OMT, which can be helpful in pain management. Last year, this House voted on the end-of-life care policy, which articulated osteopathic physicians, through their holistic approach, are well suited to provide quality end-of-life care and are in a unique position to provide important leadership in enhancing care at the end of life. This osteopathic approach helped me caring for a couple facing a terminal illness. Let me tell you a little bit about them and how this helped me. Mr. and Mrs. Cohen were patients of mine. They were in their 70s. They had no children. Mr. Cohen was a Holocaust survivor, and Mrs. Cohen had a rather severe hearing deficit. So they led a rather isolated life, but they were very content with each other in the life that they led. While under hospitalization for pneumonia, Mr. Cohen was found to have a liver mass. When I visited Mr. Cohen the night before discharge, he indicated to me that he was told by someone who visited him that he had a terminal illness. I knew them very well as their primary care physicians, and Mrs. Cohen was there, and he confided in me that they had a plan that if either one had a terminal illness, that they would end their lives. Well, you can imagine I was caught off guard and initially was trying to find the right words to say. But I basically said that I was not convinced that he had a terminal illness, but I also went on to say that I, as their primary care physician, would walk with them as we attempted to find out next steps in his care, in the care of both of them. They assured me, however, that their thoughts of ending their lives was not a consideration then at that time. Moving forward, Mr. Cohen was found to have liver cancer that metastasized, lung cancer that metastasized to his liver. And through working with an oncology team, he lived 3 more years. He remained comfortable during most of those years, despite the manageable side effects of chemotherapy. In working with Jewish social services, they became integrated into the community, and they moved into Jewish senior housing in our community. In the last 6 months of his life, Mr. Cohen's pain was challenging, but was managed with hospice care and OMT. I was convinced that OMT resulted in less reliance on opioids, which permitted Mr. Cohen to spend more quality time with his wife at the end of life, which meant so much to both of them. After Mr. Cohen's passing, I continued to work with Mrs. Cohen as her primary care physician. Through Jewish Family Services, she was reunited with a cousin living in California and lived together with her for 2 more years. The family was often expressed a lot of gratefulness for the excellent osteopathic care administered them at the end of life. And I was very grateful to be able to administer that care to them as well. Now, I'd like to move on and talk a little bit about medical education from my perspective as a former osteopathic medical school dean. It was a privilege to serve as dean of New Jersey School of Osteopathic Medicine for 17 years. It's a long time to be a dean, during which our school expanded, as you heard, to 2 campuses, and our class size grew 3 times its original size. And I had the privilege of administering our osteopathic oath to 2,433 new osteopathic physicians as they committed to preserve the health and life of their patients, to retain their confidence and respect both as a physician and a friend, who will guard their secrets with scrupulous honor and fidelity, to employ only those recognized methods of treatment and the body's inherent capacity for recovery. I would always tell our graduates that this publicly proclaimed covenant is relived in every patient encounter they would have. This commitment and passion for our profession seen in these graduates was always energizing and would always leave me being assured that our profession had a bright future. I am confident that our new DOs will proudly bring the principles of osteopathic medicine to their communities. But we must work to preserve the sacred trust and protect the patient-physician relationship so wonderfully articulated in the osteopathic oath, which is often diminished in an era of RVUs, EMRs, multiple providers, and profit-driven healthcare. Carol Trowbridge recounts the story of Dr. Still's son, Charles, obtaining the charter of the American School of Osteopathic Medicine, of Osteopathy, from Judge Andrew Elson. Elson told Charles not to fool himself, that while his father was a very gifted man, when he dies, the system will die with him. How wrong Elson was. In 1894, the inaugural class at the American School of Osteopathy graduated 21 osteopathic physicians. By the time I graduated from my great alma mater, Des Moines University, in 1976, my purple tie, it's the school's color, specifically where I wear it. The number of our colleges increased to 11, and the nation graduated 809 DOs. Today, as we heard earlier, and I'll say it again, there are 41 colleges at 66 locations across 35 states. In 2024, we graduated 8,195 DOs. Our graduates are more likely to enter primary care and more likely to practice in underserved and rural communities. Many of our new colleges are located in community-based settings, and they're starting new graduate medical education programs there where there's such a tremendous need for physicians. By 2036, our nation is likely to have a shortfall of physicians as high as 86,000, half in the primary care disciplines. Our profession is working toward addressing this serious physician shortage. Osteopathic physicians are the types of physicians our nation needs to address access to care in underserved communities and the needs of the growing elderly population. We need to continue to expand, but of course we must maintain quality. The need for graduate medical education growth is often cited as a reason to slow the growth of our colleges. However, there has been significant graduate medical education growth across the nation, and much of the growth has been fostered by our own colleges' ability to partner with new health systems to create new programs. I commend our Commission on Osteopathic College Accreditation for its expectation that growth of our colleges be linked with growth of graduate medical education. This is what I call responsible growth of our profession. Our profession's success is due to a combination of being resilient and adaptable. Dr. Still himself was resilient. He faced opposition from his own family and friends, but the profession demonstrated adaptability by embracing new approaches to education as evidence emerged, including the use of medications early on. Dr. Still wrote that osteopathy has withstood the storms, cyclones, and blizzards of opposition. His resilience has been instilled in our very profession itself as we've managed to survive the California merger, the Flexner report, licensure discrimination, the loss of the rotating internship, the loss of the hospital, osteopathic hospital system, and the challenge to the validity of our licensure exam. Moving on, this House oversaw the transition to a single accreditation system from 2015 to 2020. I have the privilege of serving as an ACGME board member. I have to tell you, my observation is that our profession is well received, it's valued, and it's integrated into ACGME governance with DOs, including residents, serving on review committees. Our performance, as you've heard, in graduate medical education placement this year is evidence of the success of the single accreditation system. I commend Dr. Boyd Boozer, former AOA president, for his leadership role during that 5-year period, working so closely with Dr. Nasca, the ACGME president, who likewise partnered for the success of this initiative. Thank you, Boyd, for your leadership in this area. Dr. Nasca said to us a few years ago, he of course is the president of the ACGME, he said, "We don't want you to become us. We want you to change us." I believe that's exactly what's happening. Our principles and practice are becoming increasingly valued for their contributions to the American healthcare system. Integral to this success that we've been witnessing has been the role of Dr. Karen Nichols, the first DO chair of the board of ACGME, and she continues to provide strong guidance to the future of ACGME. The single accreditation system has enabled our graduate medical education programs to continue training in osteopathic principles and practice by the GME programs achieving osteopathic recognition. Dr. Lorenzo Pence, a vice president for ACGME, is guiding this effort. Many of our graduates today want to continue osteopathic training in graduate medical education. However, one of the challenges that we have right now is that there are 262 GME programs with osteopathic recognition, but that represents a small minority of all of the programs. We need to increase graduate medical education programs with osteopathic recognition. I applaud the work of the AOA and ACOM that are exploring ways to assist programs in developing osteopathic recognition. Despite our many achievements, we still face some challenges. Some residency programs do not accept DOs. Some programs require our graduates to take both licensure exams. This needs to change, and I applaud the efforts of ACOM, AOA, and MBOME working tirelessly on advocacy for this issue. And I'd like to commend Dr. John Gimple, at this time our MBOME president, in demonstrating that COMLEX is the unique and valid licensure exam for DOs. As we continue to respond to the physician shortage, one of the challenges our colleges face, and believe me, I know this as a former dean, is the lack of faculty certified to teach OMM. We currently have 26 accredited OMM programs, and some of these programs go unfilled. We really need to encourage more of our graduates and more young DOs to take these programs and become faculty at our COMs. Because our COMs need these faculty, osteopathic recognition programs need our faculty, and there's an increasing number of MDs who would like to learn OMM. Our profession emerged because there was a lack of evidence of many of the acceptable interventions at the 19th century. We can be proud of the significant research that is emerging from our colleges and the increasing scientific rigor of our Journal of Osteopathic Medicine, which we learned earlier yesterday. Research demonstrating the uniqueness of our profession is needed. While there are many small studies have demonstrated the impact of our profession, there's a need for larger, multi-center trials. Currently, our colleges receive less than 1% of the NIH funding compared to 42% received by allopathic medical schools. I commend the AOA, the Osteopathic Heritage Foundation, and ACOM for supporting much of the research being conducted within our profession. But we need funding from the NIH to further advance osteopathic research. I remember how the passion for research from a former AOA president, Dr. Howard Levine, who was an inspiration to me to pursue a career in academic medicine and nurture research at our New Jersey school, how that inspired me to move in that direction. But we need to do the same today and encourage our students and young faculty to pursue careers in research. As I contemplate the future of our profession in light of the history and the philosophy set forth by A.T. Still, I'd like to think he would agree with many of the recommendations that I have put forward. He earnestly believed he was creating a movement that would transform a broken healthcare system. He would be amazed at the resilience of his profession and of its success over the last 150 years. He was a visionary, but there is still more work to be done. The transformation must continue. According to Arthur Still's book, Dr. Still said, DO means dig on. Dr. Still knew his knowledge of osteopathic medicine was in its infancy and that it would be up to others to, as he put it, dig on to further the science and art of osteopathic medicine. Today, Dr. Still's watchword is embolized on a medallion awarded to fellows of the American Academy of Osteopathy in recognition of their distinguished service. Dr. Still's encouragement to dig on should serve as our call to action to work together to improve the human condition through better health care for our nation and the world. Let us dig on. Thank you for this great honor to give this lecture, and what a privilege it is to be a DO. Thank you. Good job.
Wonderful, Dr. Cavalieri.